Our trial that we'll be presenting here in Orlando at the late-breaking abstract session was a randomized trial done in first relapse for children and young adults with B-lineage ALL. And we studied chemotherapy versus the immunotherapy drug Blinatumomab as consolidation treatment for first relapse patients prior to bone marrow transplant. So the primary aim was to compare the disease-free survival of patients from the time they were randomized to bone marrow transplant and beyond. And the patients received either 2 cycles of chemotherapy, that was the control arm, versus 2 cycles of the immunotherapy drug Blinatumomab. And so disease-free survival was the primary endpoint that we were comparing. The results showed that the experimental arm, the immunotherapy arm, had a 20% improvement in disease-free survival from the time of randomization. And so this was a very gratifying result and indicates that we have a new standard of care for these patients. So the first next step is to continue follow-up for the patients that are already on the trial. So the trial was halted, the accrual was halted early because of this difference in outcome that was evident. And so it was no longer felt to be ethically sound to randomize patients when a new, better therapy had been identified. But we have to continue to follow these patients. Right now, the median follow-up is about 1.5 years, and we need to continue to follow them to make sure that this improvement continues. But probably more important than that is we still aren't curing everyone, and we want to try to optimize the use of immunotherapy in this population to improve cure rates even further. So some of the things that we're thinking about doing is moving the immunotherapy even earlier in the disease course to help maybe even with reinduction of the second remission in the first place, or to combine the immunotherapy drug Blinatumomab with checkpoint inhibitors, which may even improve their activity further. The other thing I'd like to mention is that the subset of patients for which we're presenting results are high-risk first relapses, which means that they relapsed either early after diagnosis or they were late relapses that had positive MRD in their bone marrow after the first month of therapy. We're also studying immunotherapy in a randomized fashion in a trial for late relapse MRD negative patients, and we don't have those results yet. So the caution I would say is that Blinatumomab, I think, has been established as a new standard of care for high-risk relapses. We don't know yet whether that's going to carry over to the lower-risk relapses.